Hi there, I'm Mark Cooper and we're at the National Rural Health Conference in Blenheim. Today I have Hinemoa with me, who is a child and adolescent psychiatrist and one of our keynote speakers for the weekend. So kia ora and welcome.
Kia ora, mami.
Yeah, so I guess pretty much we just wanted to have a bit of a chat and see what are you presenting on today?
Okay, thanks for having me in your TV program. So I'm going to be talking about a number of threads that for me weave together some important ways of thinking about how we conceptualise the problems for men in the rural community around their mental health, and then those point to the kinds of solutions that might be more effective. So what we know, what we've known for a long time, is that men working rurally have very specific needs and risks around their mental health. And those are associated with fundamentally issues of isolation and also the culture of our men in the rural space, which has evolved over many generations. So I found some really interesting papers preparing for my talk looking at the coroner's reports from 1900 to 1950 about suicides in our rural communities. And essentially the themes haven't changed for the last 100 or so years. And those themes are around our men struggling in an environment where nature is the enemy. And so they're contending with the vagaries of the weather, the seasons, the brutal terrain that is the New Zealand rural environment. And so what this seems to have fostered is a particular set of values, a particular set of expectations for our men, which influences their role and how they think about their identity. So our men, to generalise, who work in rural environments tend to be very stoic, that they value action over words, that talking about feelings is to show weakness. And so those sorts of ways of being foster some things that can be particularly unhealthy.
Sure.
So these are issues like using substances in unhealthy ways, having unhealthy relationships with substances, having unhealthy relationships with people. So in the privacy of people's own homes, the reports from the 1900s are similar to the reports that we hear today, that domestic violence is a problem, that unhealthy ways of relating are a problem. So our men are under a lot of stress and they don't have a lot of skills or recognise that they have agency or mastery around how to talk about the problems that they're having. Another really interesting feature, I think important feature, is that it seems that many of these men can be going along and managing a whole lot of stress and soaking up the stress like sponges, and then there can be one or two straws that break the camel's back, as it were. And so, keeping all of that in mind, I'm focusing in my talk on two specific issues. One is suicide and one is traumatic brain injury, and also how they're related, because I think they illustrate very well the mind-body connection. So one of the problems that we have when we think about health and well-being for Western-trained medics like us is that we tend to think, oh, well, there's the mental health part and there's the physical health part. And yet we know from our own life experience and from our whānau's experience and from what we see around us that in fact these things are not separate at all.
They're all interlinked.
Absolutely. So I think traumatic brain injury is an area that I've spent a lot of time working in that field. I've done my PhD and my postdoc looking at developing a way of thinking and some tools for working with, in particular, Māori whānau who are on the journey of healing from traumatic brain injury. And so I think the brain injury is also a very good example of a silent epidemic. You know, we're very well versed in talking about things that you can point a stick at. You know, you can point a stick at diabetes, We've got some tests that show whether people have diabetes or not,
Yeah.
cardiovascular disease, physical injuries like breaking your leg. But brain injury is a little bit different, because people who've had brain injuries can have injuries in the context of violence, so they don't want to talk about what's happened.
Yeah.
And physically, to look at them, they might look absolutely fine. There's no lump necessarily, there's maybe not even any blood.
Yeah.
But even those sorts of injuries can have long-term really important sequelae, which impact on problem solving, communication skills, sleep, fatigue, emotion, aggression, even personality change. And so people who've had brain injuries, especially rurally, where we know if you live rurally, you're 2 times more likely to have a moderate to severe brain injury. So there's a very real difference for people who live rurally compared to people who live in an urban environment.
Yeah.
So I think for me, wanting to talk about brain injury is really salient, I hope, for the audience today, because it might be a minimised kind of injury and it has lots of effects that can impact on suicide risk.
Yeah, for sure.
And then I also talk about some specifics around suicide risk. So we know that there is a difference in the suicide risk for people rurally. It's actually quite hard to get good data about this. And as we know, the data is an underestimate of what's actually going on and the level of distress.
Because they don't necessarily come in, do they?
No, so people who are thinking about suicide aren't going to come forward with that. And even people who kill themselves, they might be in a drowning, they might be in a car accident where it's actually unclear as to what the intention of the person was.
Yeah.
So we know that the rates of suicide in the rural community haven't been decreasing. They haven't been responding to some of the community investment in attempts to alleviate distress in the community. Mm-hmm. So I think all of those things together point to some very specific needs, and to look at what really works for people rurally. And my sense is that the service-based approach it's a necessary but not sufficient approach. Yeah. Yes, we need services. We need mental health services that think holistically, that think outside of this kind of rather circumscribed way of conceptualizing what mental health problems are and how they might present. So we need services that think creatively and broadly and think about people's whole lives, and that life is messy and difficult and challenging, and the way that people might be presenting to us on their best behaviour in our clinics is probably not what's going on in the home.
Exactly.
And also we need community approaches that foster connectivity.
Yep.
So coming back to the idea that isolation and all the things that hunt in a pack with people being isolated is at the core of the problem. So if we can actually build more connectivity into our rural communities, we're going to get a lowering of the risks, a general lowering of the stress. Mm-hmm. Things like pricing of various commodities, the weather, all these unexpected things that can happen for people. Making sure that our rural men in particular feel that they have more of a buffer zone emotionally. Yeah. And I know that there have been some really great efforts. There's a fantastic resource called Down on the Farm for Wairarapa and the Tararua area that I've been looking at. And it's essentially men reaching out to other men and saying, look, this is me, I was depressed. It took ages for me to even come out of my state of denial about it and begin to find words to express it to my partner, to my friends, and trying to lay out a kind of a map for other men working rurally, and particularly some of our young labourers. That seems to be another risky kind of a job. Yeah. I think there was the idea that it might be some of the people who were perhaps the landowning type group who felt more at risk in terms of their intergenerational family investment in that land. I think there are some particular risks for that group, but actually our our young labourers for home employment is less secure. They seem to be a particularly high-risk group at the moment. So I'm trying to weave those themes together this morning and to really advocate for community cohesion, as opposed to, well, alongside, shall we say, complementing a health service model.
Yeah.
So those things need to work in tandem, and there needs to be really good communication across our rural communities if we're going to deal with this significant problem that we have with men's health in rural communities.
Exactly. And I think you summarised it well, that, I'm from rural Southland, and
Yeah.
you're not going to see any of my mates walking into a mental health service, but I'll sit down with them. We meet up a couple of times a month, and we'll have a beer and dinner at the pub, and
Yeah.
I just straight up ask them, because I feel obliged to, just, how are you doing? Then they go,
Yeah.
I'm good. How are you actually doing?
Yeah.
And then,
Yeah.
the stuff comes out of the closet.
Yeah.
I hope that, they feel better for it by the end of it.
Yeah.
And I've even had some of them come up to me afterwards and go like, thank you for talking to me last week. It was just a yarn at the pub, but for them it meant a lot more.
I think that's right. I think finding the right person who's at the forefront,
Yeah.
and also finding the right way to frame the conversation. If it feels like a clinical assessment
Yeah.
from a psychiatrist, somebody like me, that's not going to get the right outcome that we're wanting. We want a sense of intimacy that feels comfortable. My grandfather was a dairy farmer from Hinemoa in the far north, and then had a farm in Bombay and had a farm in Tohei near Morrinsville. So I've grown up around our farming guys, and they're pretty staunch.
Yeah.
And so that's not going to change. And there are some things about that role for men that are healthy, but not all of it. So I think it does take younger men of the right generation like yourself, health professionals who come from that community, to be part of the solution.
Cool. Well, thank you very much for having a chat with us, and I look forward to watching you talk in probably about an hour or so now.
Yeah. Kia ora.
Thank you.